Hi everyone, and welcome back to yet another episode of Circling the Rabbit Hole podcast. By now, I think you know the theme of the day is subscribe, subscribe, subscribe. Tafadhali, the one way you're going to keep these episodes coming and all the information you're getting is by subscribing. I'm not even asking for Hakuna M-Pesa. Just hit the subscribe button on YouTube, on Spotify, or any other platform. And if you're listening on audio, please rate the podcast as well. It goes a long way. Today, I'm having yet another very informative conversation around physical health. We cover so many aspects of especially so sexual, reproductive, and related mental health. But this is yet another one that's primarily physical. But of course, as we've seen in women's health, it's very rare that you're going to have a physical issue without the related psychological and mental issues. And today's topic is one, again, highly requested. I get a question about it pretty much every day on my social media. And again, I keep encouraging you guys, keep sending those DMs, those emails, leave a comment, like, follow, all of it so that we can continue to engage. But this topic specifically is coming from all age groups. It's not necessarily older or younger. I just see it across the board. And this is to do with fertility. Having babies, having the choice to have babies, deciding when you feel you're ready to have a family, that's what we're going to talk about today. And I did what I do best and found the expert in the field. Because as you know, on here, I like to pretend I don't have medical knowledge and bring my colleagues, bribe them to show up for a few episodes. So that's what we've done today. I'm joined by Dr. Muchiri, Dr. Dorcus Muchiri. Again, if this is the first time you're seeing her on the podcast, do better. She's been on the podcast before, and it was so informative that you guys have demanded that she comes back on. So, Dr. thank you so much for joining me today. I'll ask you to introduce yourself because we have a few people who haven't seen you here before.
The newbies.
The newbies.
Thank you for having me, Claire, as always. I'm such a huge fan of the podcast because every time people ask me questions, I go like, just go to this podcast. She does all those questions you're asking.
And you go and find answers.
Yes, go and find answers. I can't do that job also as other things I do.
Yeah.
So rightly, my name is Dr. Muchiri, is formerly my career name.
Okay.
Dorcas is friends, and I have nicknames also.
Yeah.
Yes, so but
see, I've not mentioned nicknames. I am keeping it PG.
Very.
We go way back. So
so we've known each other for a long time. I'm impressed that she still remembers my formal name. This is good.
Government names.
So Dr. Muchiri, I'm an obstetrician and gynaecologist. I'm a consultant, and I've also done a subspecialty in matters of fertility, so reproductive endocrinology. I'm currently practicing in two different places, two different continents, and this is purely out of just interest and living life fully. But from where I stand, then it gives me a very nice view of what's happening in Kenya, where I'm trained, and abroad where I work.
Okay. Yes. I like the balance because again, you've found the magical sweet spot between the two worlds.
It's very, very nice. I really enjoy it.
Yeah, so we shall sidebar for tips a bit later.
See me.
See you hapo kando. Hapo nyuma ya tent.
Kwa tent. Yeah.
So I think then you're the best placed person to have this conversation with because, like I said, the questions have come in hot and heavy. And fertility is like a hot topic, especially in Kenya now. And we see it from different angles. We see the side where women are keen to have a baby and they come in because they're trying and nothing is happening. We also see it where women are having as many babies as they can possibly have. And then we also have those who have chosen to be child-free. Yeah. And we're going to touch a little bit on all these two
very exciting
different aspects.
Yeah.
Just for those who are watching and don't fully understand what we mean when we are talking about fertility. So is it the same? Because again, doctors, we use them synonymously. Fertility, infertility, subfertility. Yeah. What are these?
So fertility, I mean, in simple terms, fertility is the ability to conceive. So infertility is the inability to conceive. And how we define that is based on time and how we are doing it. And I'll just put a caveat because I've had some interesting infertility couples in my lifetime, including doing sexual intercourse the wrong way. So if you do engage in sexual intercourse in the behind passage or in your abdomen at the umbilical, that is not infertility. I just put a caveat.
Okay.
Okay.
Again, I'm not surprised because you see it, you hear it all. You're like, okay, you're not conceiving. Okay. Yeah. Graphically explain to me how you get, what do you mean by you are trying? Yes, how are you going about it?
So you've got to be having regular sexual intercourse. It means you're not having sexual intercourse once a month or when you feel like.
Or when you see each other.
Or when you see each other.
Together. Yeah.
Or just around the 15th day when you think you're ovulating. Yeah. Regular sexual intercourse is 2 to 3 times a week. It is every week. It is for 52 weeks. The men love this definition. They love it. They're just like, yes.
They're like, twende kazi.
The women, on the other hand, just go like, what?
What do you mean?
That is
every
too
week?
much. Every week.
For all weeks of
For
the
all
year?
weeks of the
what
year.
What are you saying?
Yeah. For 52 weeks.
That's
365 days.
3 times. Daktari, you're asking a lot.
Oh, no. That is, and I'll explain briefly why.
Right.
Because, so going back to just describing how babies come about, which is something I feel we've probably not been taught very well in school. You've got to have an egg from the lady, you've got to have the sperm from the guy, and then you've got to have tubes, both for the men and the women, that are open and working. Fertilization, which is the meeting of the egg and the sperm, normally will happen in the tube of the lady. The tube has to be open. So if we had some models, I should have carried a model. That would have been very useful here.
I will find diagrams
and put and attach. Yeah. So the man has... Well, I say man here very loosely because it doesn't have to be a man.
We're keeping
My
it
job,
we're keeping it
very open because it can be that it's not a guy, it can be me who's putting the sperm.
Yeah.
So where we deliver the sperm is through the vagina and the cervix, which is the neck of the womb. And then you've got the uterus, which is where the pregnancy happens, like where the baby implants. But that bit comes after the egg has come out of the ovary and met the sperm in the tube and then come into the uterus and sat there. Okay. So if you think of all those dynamics, the egg normally is produced one egg per month, and it's not all months that will have eggs. So sometimes you're a bit stressed, you don't ovulate, it can happen. So it's not that every month we'll have an egg. We have what we call anovulatory cycles. So you'll still get a period, which people get fascinated by. You get a period, but you didn't release an egg, and therefore you didn't get you couldn't have gotten pregnant that month. So so when you bring those things together, the egg, for most people, if you've had what is a regular cycle, by regular, normally we want anything between 21 to 35 days. So sometimes I get patients who say, my period comes after 30 days. Like, is that normal? Or it came after 3 weeks. Especially the 3-week ones, they usually feel like that's abnormal. 3 weeks is 21 days. That's a normal cycle. 35 days is a normal cycle. But what we don't, it's difficult to teach, like in a school when you're trying to teach something general, is when you have a 28-day cycle, you've most likely ovulated on day 14 of your period. So if you have a 21-day cycle, sometimes, very oddly, you've ovulated when your period is just coming to an end. Which is very fascinating for most people because
most people there's a belief generally that you cannot conceive when you're on your period or you're coming to the end of your period.
Exactly. So these are the ones who are 21 days, and then 35 day cycle will usually be about what is that, 21, maybe about 21 day 21. So that's important to understand. So if you don't know when you are going to ovulate, then you cannot place a time when you're going to be having sex to try and have a baby.
Exactly.
This is where the 2 to 3 times a week, every week, 52 weeks comes from. Yes.
It covers for everyone.
For everyone.
Regardless of your cycle. Because again, we say the normal range is 21 to 35. It could be 24.
Yes.
It could be 32. It could be, it's anything in between. So you kind of have to know what your cycle is to be able to estimate when ovulation is happening. But instead of all that mental mathematics, what we are saying is 2 to 3 times a week, 52 weeks of the year.
Yes,
Oh,
yes,
well,
yes.
I can already
So if
see.
you are a teacher, for example, who lives in Coast and your husband is in Kisumu and you meet over half terms and holidays, to me, you are not trying to conceive.
You're not trying to conceive. Exactly. And that's the conversation we keep having.
Yeah.
If you don't live together, you're not seeing each other regularly enough, we are not going to start intervening. You're not yet trying.
Yeah.
It doesn't qualify.
No.
If you are timing only for day 15 of every month, peke yake, you're also not trying. You're also not trying to conceive.
No.
So it's a bit more intentional. It's a bit more, like you said, people don't understand that because I'm having a regular period, it doesn't mean I'll ovulate every month, and it doesn't mean I can conceive every single time.
Exactly.
Yeah.
In fact, interestingly, it's just about 11 to 15% chance that you conceive per month. People really think it's a huge number. They think it's 100%.
Yeah.
And that probably comes off the bat of, if you're much younger, it's quite easy because your eggs are present, they're good quality, it's easier to get pregnant when you're younger.
Yeah.
But overall, it's actually quite hard. 11% is quite a small chance.
Yeah, that's true. That's true.
Small, yeah.
So again, just informing everyone that the more you're trying, the better your chances.
Yes.
Right. So then now we start to explore fertility in the context of our culture.
Yeah.
The burden is placed on the women. True or false?
I must tell you where my interest started from. I was an intern in Machakos General Hospital, and I saw a lady, and I believe I saw her 2 or 3 times over a course of 3 to 4 months. And she would come every time and say, I've not gotten pregnant yet.
Yeah.
And we'd done all the investigations, including looking at whether the tubes are open or not. And there was no problem with her.
Yeah.
And every time I would say, please don't come back if you don't come back with your partner. Because baby making is not a one-person affair. It's not one person.
Yeah.
And it was quite unfortunate. Eventually, when he came, we did a test, and the guy had no sperm, 0 sperm.
Right.
So there are reasons why that happens, but it's really unfortunate that it's a woman's problem. The infertility will affect 1 in 7 couples. So if you're about 7 couples, then one of that couple is going to struggle.
Right.
But it's man and woman, and we must just recognize babies are not made by women only.
Exactly.
Please don't come to my clinic without your partner. Don't bother.
Come with the person you're trying with.
Yes.
Because how else
come
will
with
we know
whoever
what's
you're.
going on?
Yes. And if you are 2 ladies, we can help that way. That one I understand.
Yeah.
But
because again, honestly,
or if you're a single lady,
and
I can help with that also. I know where to get the other part of the equation.
Exactly.
But if you're with someone and you're really trying to conceive with them, don't present yourself by yourself.
Yeah, because it's, again, in practice, it's so common that women will come, I'm concerned, I'm not conceiving, keep coming back in. We do the most invasive testing. Yeah. It's quite uncomfortable for the most part. And then everything is fine. Yeah. But your partner, and then the statement, uyo hata kuja.
Yeah.
Oh, that
in
one
fact,
is okay.
the women
Him
defend,
is fine.
And they're very quick to defend.
You know, he has a baby somewhere else,
Yeah.
so he has children. He had children with someone else. And I'm like, we still
I don't
need
care.
to test.
I don't know.
Yeah.
Are they his babies?
That's another question.
I can never assume.
This one.
Yes.
Yeah.
So
culturally. You know how you start seeing comments and you're like, this is going to be problematic. But
in fact, sometimes my patients really think I'm very tough because even the men will go like, I have 2 children. I said, have you done a DNA test? No, we don't know. They could be anyone's.
We were taught in school though, the only person who knows paternity is the mother. Yeah. So up until you're both tested,
stay informed.
Yeah. And I think there's also fear around being told something is wrong, something we see culturally. It's like my attitude is I would rather not know.
I think that's sad because if you are keen and you're trying to get a baby, 13 years down the line in a marriage, I don't think it's useful. It's not useful for even your mind. You don't need to wait. Yeah. And there are different reasons why you could not be conceiving, including the fact that you might not have a uterus. So what are you doing? Yeah. We should have already moved on to find how we can help you carry a pregnancy, even using your own eggs. Yeah. But someone else can carry a pregnancy and that baby will be yours.
True.
So that fear, we just need to get over it. Otherwise, we're wasting a lot of time.
True.
I've got couples who are 15 years into a marriage and they haven't had children. They just go like, what were you doing?
Where have you been?
And you are the one who wants the baby, and you've not actively made the decision that since it's not happening, I'm not going to then keep pushing. That's different. But if you do want babies, please don't wait. Actually, I say by the first year, once you've gotten to the point 1 year, you've been having regular sexual intercourse, it's not happening, please see a doctor.
True, I agree. We understand, of course, from the stigma side of things, because again, like we said, it tends to be culturally such an important thing to have children. You get married to have children. You have a relationship to have children. Sometimes you don't even have a relationship, but you want to have children. So in that space, I understand where the fear comes from not wanting to know or being afraid to follow up if you think there's an issue. But again, like you said, instead of wasting time, especially given that prime eggs, age is a factor here. So one of the things I think also we'll cover in today's conversation is the fact that we have options. We have so many options now versus where we've come from, where the stigma was really bad because if you're not having children, you're thrown out of the home and someone else replaces you. Or again, like we've said, you'll be thrown out. So then you desperate measures. I'm going to have babies, whether they're yours or not. We're not going to discuss too much. And in the scenario we're in now, options, you're almost drowning in terms of options. But at the same time, I don't know, maybe now you can comment from your experience, the numbers we're seeing of people struggling with fertility.
That's, it's quite, it's a lot. And it's probably coming from the education that we've had for quite a long time, asking women empowerment. I'm such a big believer in women empowerment.
Absolutely.
And we've empowered women to be, go to school, study hard, chase your career, which is all good. But as a society, we've also forgotten to tell women that you've got to think in advance, do I want a family or not? It's not about like when. It's do I want or do I not want? If you don't want a family, that's absolutely fine. But if you're 20, for example, 21, 25, and you're saying, yes, I'd like to have children, you better start thinking.
But I'm not ready now.
I'm not ready now, but you better start thinking because coming to me at the age of 40, 45, I've got 50-year-olds and I feel so heartbroken because I'm like, wow, we had 20 years to do so many things.
Do something. We had
options. We had a lot of options. So it's also disheartening for myself as a doctor to see you as a patient. It's very distressing. So that thing that you said, culturally, probably needs a bit of a shift in how we think. We are not saying people should get pregnant at 20. In fact, I don't want you to get pregnant too early. It's not safe for you. But to be able to think in advance and plan. Prepare and plan.
Let me put myself in character. I am Mama Sandra. She is 18 years old because now this is things we see in the clinic now. She's 18. I am bringing her in for her first review. And one of the things I want us to talk about is her fertility. Because you know what? I'm telling her, first of all, don't talk to boys, you'll get pregnant. And this is not the time. But also I've seen, from what we've seen in society today, we were all told the same thing and we are all leaning towards not having babies at all. So, but I'm concerned. I want her to be the best she can be. I want her to chase her career up until the point where she's happy. And then when she's ready for babies, she can have them. What are our options at this point where she's 18?
Okay. So first things is to educate, she's Sandra. We need to educate her. It's very small. It sounds small, but it's not small. The most common cause of infertility in women is blocked tubes. The blocked tubes are coming from multiple sexual partners. We're having girls having sexual relations much earlier, multiple people, and then your tubes block. Usually the commonest cause is going to be chlamydia or gonorrhea.
Now, so your sexually transmitted
infections, which sadly for women might not give you a symptom. Sometimes chlamydia will not give you, you won't know, and you'll never know that you've got blocked tubes until much, much later. So first to educate our girls and even our boys. It's important to educate even the boys, the men, this multiplicity, many
Nairobi.
people.
Many a song has been written.
I was trying not to talk about Nairobi.
May I say it as it is?
I attended a comedy show and they did a segment on the Nairobi School of Relationships.
Right,
So
yeah. School of Relationships, of character
development,
person sharing,
yes,
all
they
of
should
it.
have added there of infertility also.
Yeah.
So education for our younger, and I say this, I mean, by young, this is anyone who's age of, I've seen 15-year-olds who are sexually active, all the way to your 40s, 50s. Anyone who is trying to get pregnant, just be cautious, because if you're not looking to get a baby, then use some protection.
Yeah.
Otherwise, we are seeing a lot of tubes. And this is about 45 to 50% of infertility is from the tube in itself.
Tubes, yeah.
And then we want to discuss her diet and exercise and nutrition. An 18-year-old is so free living. I want to remember when I was 18, I had no care in the world.
Eat the mandazis and the chapatis and the chips.
The chips. And the Coke that I used to drink, Coca-Cola. Wow. Bad
because
news.
your body does not change.
Doesn't tell you
anything. It is
anything.
doing what it is doing at its prime.
Your metabolism is fantastic. You're playing sports. You can.
These days you look at fries sideways and
be cautious. But those things that we've done when you're younger have an impact for you also in future.
True.
There's a big study that showed that even ladies up to the age of 25 on a very poor diet will struggle to conceive by the age of 25.
Right.
So that's important for us to be aware about. So talk to her about lifestyle, alcohol, smoking, all those things, especially smoking. And the problem is we don't know what we are smoking. We know traditionally it is tobacco.
Yeah.
But my goodness,
nowadays,
you guys are
honestly,
smoking everything. Trees.
The devices I've seen these days, by the way.
They have gadgets. They sophisticated
you
smoking
wouldn't
technology.
Even know what is happening until you see it in action. You're like, what
wow.
is that thing?
And it is colorful and it is attractive.
Right.
So we don't know what all those things are doing. But traditionally, tobacco will actually hasten, kuharakisha kwa Kiswahili, the loss of ovarian function.
Right.
So it actually kills the ovary function. Now, this ovarian function, let me just describe that you have a set number of ovary eggs.
Eggs when we're born.
When you're born.
Yeah.
From when you're born, they start deteriorating. Yeah. It's in like fact, a car.
To my patients, I describe the body, the system, the in women, the fertility system as very wasteful. Yeah. It is diminishing returns because the number of eggs you lose before puberty. Yeah. For no good reason.
For no reason.
For unprovoked.
No, just, in fact, from when you're born, as a neonate, you're just brought into, it's almost like begin to deteriorate.
Yeah, immediately. Just by birth. Yes. So you've already started losing eggs. Yeah. And then puberty hits, and the fact that the thing that most people think is that you only shed one egg per month.
Oh, yeah.
Rumor has it.
That's a rumor. Rumor
has it.
It is not one.
And yet we know how wasteful the system is. You recruit several eggs.
Yes.
The one that wins that race is the one that gets released. Yeah. Everything else, you have no access ever again. Yes. Yeah. So it's a very wasteful system. So to sit and think that you have
already something that is already working against you
and
then you add,
and then add on now lifestyle
now you
issues.
Add your smoking, you add your poor diet, then it's basically, in fact, you are just telling us, let's quickly finish these eggs and move on to other things, which is really not what you want to do if you're looking for a child. But then having those conversations is also about asking, do you see yourself with a family? And I think that conversation has been very sort of put at the back burner, like you mentioned. You'd probably be encouraging her, in fact scaring her. If you get it's either, if you get pregnant in my house, I'm going to kick you out. Very common for some cultures. The fathers are the ones who are kicking out their children. It's really sad. But also we're telling our women, we want you to be the president of this country.
At the same time,
how can you be a president if you have children?
Having children from
so
age,
that, the conversation is very skewed. It's been made to look like if you're a mom or if you have children, then the rest of your life basically is non-existent, which I don't think is the case. We've got brilliant moms even in leadership and doing very big things. So having that conversation freely without scaring the ladies. And have them think about it early, because then you can take some of the eggs out of the system, and there's technology for that. That's called egg freezing, and you can keep that on the side. It's not 100%, But at least if you're coming to me at 40 or 45, we've got young eggs that give us better outcomes.
My 25-year-old eggs waiting to be used.
They're fantastic. I really like those eggs. I don't like this one.
They're high-performing.
At 45, the success rate for IVF is literally like 1%. It's worse than even trying to get pregnant by yourself.
Right.
So that is an option, and it is available. Okay, but it may be that it's just a conversation. You might find someone says, okay, so maybe I can be able to get a child and do other things. But also as a culture, we need to rethink how women exist in our societies, how people are not working part-time jobs, why you can't take a bit of time even out of medical school is really bad with this. Like you can't, it's almost like if you miss out of 3 months, that's
honestly,
it.
You can't even have a baby during med school without being penalized.
I
mean, it's sort of repeating a whole year.
It's really, really unfortunate. I think we should just rethink the entire thing. You have high-powered women in corporate who, you can't even go for an interview for a job because they're going to see me pregnant and they'll
actually
they won't
not
give me the
you.
job. They won't hire me. Those type of conversations, I think, just need to stop, change completely. We must allow women to exist within the things that they've been wanting in their dreams, but also other things.
I like that because, again, balance is key. We want to continue to empower women, allow for women to work in all the same spaces as men, compete aggressively, actively. But again, we also have to think about the fertility side. And so giving better equity. That's the conversation around equity. Giving better opportunities for me to be able to thrive, both as a mother if I want to be a mother, as well as being that corporate buddy. A bit of balance. So I was Mama Sandra. And then we always focus, like we said, fertility is a women issue. Please, this conversation will not continue to propagate that myth. Male factor in fertility. Talk to me and the men about that side of things.
Hot. I have no idea who made us, I'll say us, but more so men believe that they are the it. I mean, they are. I mean, they're leaders, they're, But we are humans, and we can be imperfect, and we can be affected. Sperm issues come a close second after the tube, and sperm issues are a whole range. So for sperm to be considered normal, the World Health Organization has given us like criteria, and in the sperm we look at how many there are, which is the numbers. It's called concentration. We need 15 million sperm.
We're talking millions. To the one egg.
That one egg. 15 million plus. So anything less than 15 million is we are playing games here. And then we want to see how well they're moving forwards, which is called the motility. Nearly 32%. They must be, this 15 million, 32% of them must be going forwards. Because people don't know. Listen, that sperm can just do some strange things. Do you remember,
because we were in class together when we had this session, do you remember the first time you looked under the microscope? At a seminalysis sample, and there's a guy doing like this.
It's
just vibrating on the spot.
What is that? This I'm like, Kenyan songs that are being played. That's what it's just doing. It's not moving forward.
Because me, as far as I knew,
going round in circles.
Or really, literally just going round
going backwards. We are all going like
just
this.
Not moving.
I just want to go like this.
I'm just samabani. I mean,
or not moving. Or it's a head. So the sperms usually have a head, a neck, and a tail. It can come just the head.
And that is completely useless.
And it's just chilling. And it's just looking at you. It's useless.
Completely. And again, just to quantify, the 15 million, is this my capacity as the man?
No.
Or what are we talking about?
Here, the 15 million, before we get to there, the third parameter is then how they look. So like I said, you can have one head. You can have two heads and two tails. You can have, they're attached. It won't fertilize. So it needs to be one head, one neck, one sperm that goes forwards and goes and talks to the egg.
Meets target.
And meets the target. Otherwise, they just pass by. If you look at even lots of videos, it just passes and the egg is just there going,
Do you not see me?
Am I not shining bright like a diamond
in the sky? Am I not beautiful? What are we doing?
So this is a small problem. So now to come back to your question, the 15 million is per ejaculate. Men are so endowed. I feel like sometimes, I feel like, I don't want to quote God, but Surely.
How?
That's 1 egg per month.
Yeah.
But the guy, 15 million per ejaculate.
And this is minimum.
This is the minimum.
This is the minimum
that
we
is
want
required.
to see. Yeah.
Sasa 2 to 3 times a week, like we've said. Imagine.
That's
already 45 million. That's like that.
Cheap,
and that's
quick
one.
Fast, quick math.
That's one ejaculate. Some guys are like 2-3 in a night.
And that's we're saying 2-3 times a week. How many millions are we talking?
Millions.
Right?
Millions.
Yeah.
But for men also, their lifestyles are ridiculously poor.
Mm-hmm.
And some of the things are things that we don't think about traditionally.
Yeah.
Sometimes I tell men, when I look at their semen analysis, I tell them now, I'd like you to go and exercise. For some reason, most men think exercise is go on a bike. I don't know. Men, there are other ways you can exercise.
Call in and tell me.
Yeah, please,
send that email.
You can see Dr. Claire and ask other types of exercise. You don't have to go on a bike.
Yeah.
You don't have to go running a marathon and wearing that tight-fitting stuff, please.
Those two boxers,
those
two
boxers,
extra small.
they look so nice, guys, on the Calvin Klein poster, but they're very bad, very bad.
Exactly, because temperature is
it's a thing.
Such a thing.
It's such a thing.
Yeah.
Anything that brings the testicles close to the body, naturally they're supposed to hang and be loose and be free in the wild.
And honestly, the hotter it is, they hang further.
This is the reality, drop
right?
properly because they're looking for air.
Yeah.
So if you're a guy and you want to sit in your office all day and put nice Calvin Klein boxers, and I have nothing against Calvin Klein, let me disclaim, I really think they are fantastic, those Calvin Klein ones. But
we appreciate
for my
the
job,
billboards. So.
For my job, they may not be so, But they make now nice ones with the space for the testicles.
Things to breathe, yeah.
And then you put your laptop on your thighs. And then when you finish all those, you say, now I want to relax. Then you go to Kempinski, nothing against Kempinski. You dip yourself in that hot jacuzzi business and you just chill there.
Or you go to the steam or
and the
sauna.
Steam room. What's a steam room? They like those guys of clubs. They like that stuff.
Do a round of golf and then steam.
Yourself. You just know you're just steaming.
Elimination of our millions, guys.
Please.
We're wasting.
So it's very simple things. And in fact, the sperm and the testes are usually very forgiving because the sperm is made in 3 monthly phases. So the fact that today we've seen sperm that doesn't look very great, you can change things, and within 3 months,
you see
quite a significant difference.
Yeah.
So the other things are smokers. Most men are, most fertility problems with sperm, you'll find those guys will be either smoking, they'll take a lot of alcohol, Friday to Sunday, sometimes every day. Alcohol is a major problem. And then, of course, when you're having those, you're socially out, you're eating badly. You're just eating lots of meat and stuff like that. So lifestyle, very important. Now, you can have genetic problems as well. So you can be born with, for example, the tubes where the sperm doesn't go through. That can happen. So it's important to be checked. This is why I like to encourage men to come.
Come in.
Because if you don't come and I don't see that it's 1 million sperm, for example, and start to think, is this something that's genetic? Then we can assess and we can look and say, all right, we need to get sperm directly from the testes rather than having you ejaculate to give us sperm.
Exactly.
So there are solutions to all these things. Once you overcome this culture business.
True, because that's the thing that fascinates me about culture. Men are so afraid to come in for a checkup, and yet the issues we find are the easier to fix.
Yes.
And so if you come in and we catch an issue, like you said, it's a 3-month cycle. We change behavior, we change lifestyle. If it's medication, you'll be put on. If it's supplements, if it's, like you've said, having to retrieve directly from the test, we have options. So this is not the attachment between the male organ and ego. I fail to compute. And so just to encourage the audience, please, if there's an issue, come in with your partner right from the beginning, because instead of wasting months doing much more invasive testing on her and ending up to find that she's fine, we could catch an issue, fix it in a few weeks' time, because we're talking 3 months is what, So, and then
we'll be able to solve.
And
even for couples, stuff like erectile dysfunction can be quite a big deal. So you're not having regular sexual intercourse because there's a problem. Either the woman is feeling a lot of pain, so you're not having things like endometriosis can be quite uncomfortable. But for the men, erectile dysfunction linked to diabetes, hypertension, and other things.
And alcohol and smoking,
and lack
some
of
medications.
Sleep is poor, stress. So it may actually not be a problem with the sperm and the egg. But if you don't come, then we don't pick out on those issues.
Exactly.
Then we are just fighting a losing battle.
Exactly. So again, just to highlight key points, fertility is not just a woman's issue.
Yeah.
And it's likely that we can fix a male issue faster.
Yes.
So male factor infertility, if you can come in and have a diagnosis. In fact, I'd even go as far as to say, just come and have a checkup.
Yeah.
You should be having your annual checkup anyway. Why don't you just say, Daktari, also check if the boys are okay.
Yeah.
And check if my swimmers are doing what they need to do. And if not, what do I need to do to change it? So that it's not even something that's being found out in the shame of, I'm failing my partner.
Yeah.
You know? Hopefully we'll start to see change.
Hopefully. Hopefully. Please. Yes.
Right. Before we go too much further into the specifics in terms of the exciting options we have when it comes to assisted reproductive techniques, child-free. I'm choosing to be child-free. Africa, that does not compute. What do you mean by child-free? What does that even look like? Because again, I don't know. We tend to be in denial. We don't talk about these things plainly. And yet, in practice, I'm pretty sure in your practice as well as the way I see in mine, these are conversations we have where, because we're gynecologists, we tend to see women. Yeah. And so they'll come in and say, right off the bat, listen, tie my tubes. Yeah. Listen, I have no interest. Put in that IUD and we shall never discuss this ever again. But what are your thoughts, and why do you think we are seeing more and more young people? And I promised you, Gen Z, you guys have really
decided.
You have really decided. Yeah. Maybe just from your experience, what have you seen when it comes to making that decision? Yeah.
I think child-free, first, people should be allowed, I think if you're above the age of 18, you're over the law. You can be arrested if you do something illegal. Yeah, and you should be able to make a decision. And that's a big decision. I say that's a big decision because I think people who make that decision often are coming from a place either of trauma or of fear. You can find someone who's really afraid of the thought of labor and being in labor and being in pain is so gripping. It's called tocophobia. It's so gripping that you then say, I don't want to have children.
Even think about it. Yeah.
You could have had a child before, and now that was so traumatic, you don't want other children. So that's a different sort of angle to it. Yeah. So there's issues usually that I like to explore. What is this that's making you want to be child-free? Yeah. You could have been the firstborn of 15 siblings.
Yeah, and
you
have
still
no interest. In fact, you have children.
You're
raising them. They're yours.
And especially in this day and age, the economy is just not allowing us to explore, options. So I normally say your age of 18, you should be able to make that decision using information. You should be informed. Yeah. Most of our patients or our clients have not had the information. For example, and I'll tell you now from fertility, I've had patients who've chosen to be child-free to a certain point. And then they come at 40 and suddenly it's like something just clicks and they go like, I want to have a child. Yeah. Okay. Yeah. When we tie tubes early, and some people really, really complain and say, that doctor is refusing to tie my tubes. It's just being intrusive and invasive.
You're taking over my autonomy.
Over my autonomy. It's not because we just randomly, spontaneously decombust into these decisions. It's because you then come back when you're 40, 41, and now whatever that thing is, I haven't understood what it is, makes you come and say, I really want a child. And there's a risk of regret. Whilst it's a small risk, there's always that risk. So for my patients, I usually go and say, I want you to think critically. You would rather have a longer term contraception. Things like the coil and Mirena, beautiful, fantastic. You can stay with it for 10 years. Exactly, meaning you don't have to think about this child business until you're 10 years. You can have your eggs frozen, even when the Mirena is still in place. So say you had a Mirena at about 20 and you're now 30 and you're like, maybe I'm starting to think, maybe I might want a child. Then we can freeze your eggs, remove that Mirena, put another one or a coil, and you continue to stay in that space. Yeah,
but you're keeping your options
open. Yeah. But we want to be informed by the time you're making that decision. But even for society, we should be able to allow space for someone who's made that decision, having understood the backstory. True. If someone tells you my sister died when she was delivering, it's very unlikely that they will be like, oh yeah, I also think I should just get children.
True.
Yeah. And just, I might die, but no. We must allow for that space. Most people who make that decision have just not woken up and decided, I hate children.
Yeah.
There are a few people who, they don't have that maternal instinct. It's not there. It's never been there. It's not going to come. We should also allow for that space. It's not everyone who has been spontaneously built to reproduce and have babies.
Yeah.
Some people like dogs and cats. Some people don't like humans generally.
Just generally speaking. So now you're asking us to increase the numbers.
To increase them and to bring them closer to our space and interfere with my life.
Yeah.
It's a bit, So I support informed decision making and having these types of conversations. Listening. If you're a mom and you're 45, you're 50 and your child is starting to speak, don't... some parents, and it's unfortunate, they take this so personally. It's like they are refusing to give me a grandchild.
It's like an extension of me. You're really insulting me as a person.
And our line will not be...
The heritage, the legacy.
No. There's so much that's come up in recent years. I think our parents were so lucky, when I think about it, in that way, they were lucky that they didn't know what we know now.
True.
How many times would you have known that a woman has died in your village from bleeding to death?
Exactly.
Now that information is all over the place,
Yeah.
We've got women gynecologists and obstetricians. Now we've got more women obstetricians and gynecologists. So they're talking also to their friends and saying, this is what I see on a labor ward.
Yeah.
And inherently then they'll be like, I don't want to be in that position.
Yeah, true.
So our lifestyles, our things have changed, and it's important to just recognize that.
So it's I mean, again, just to summarize, I love that we can openly discuss options, and I think respecting people's options. We were not created the same. We were not supposed to be photocopy of each other. If you've come to the decision and you come in and we have a full conversation and you have all the information to make your decision, it's not my place to then force anything on you. But at the same time, if you don't have enough information, keep an open mind and let yourself be educated, so that now by the time you're arriving maybe at the same or a different decision, you're coming from a point of information. Right, now into the fun part of fertility. So IVF, kila mtu anasemanga tu IVF. Is that what assisted reproductive techniques means? So ART. When we're talking about ART, is it just IVF?
No, it's many other things. It's a whole scope of treatments. So remember how we started with problems of the female and then problems of the male. ART addresses any of those problems, including being single and not having the right partner and trying to get a baby. So that's all assisted reproductive technologies.
Right.
And if you think about how the system we discussed earlier, if, for example, it's the tubes, which is the most common, you can have eggs and you have a uterus, but they're not going to meet with the sperm because the tube is blocked. ART, which is now what people assume is everything plus, IVF. IVF is getting the eggs out of the female body and taking sperm out of the body and combining them outside and then putting the embryo back into the uterus of the lady to carry the pregnancy. That's what IVF is. But if you don't have a man to have sexual relations with, then we can get sperm. Someone has given us sperm. The someone could be a friend, could be someone you don't know. It's different in different countries. And we can put the sperm directly into your tract. And that's intrauterine insemination. It's still an assisted reproductive technology. Yes. So there's different sort of things. Now, IVF can also be something called ICSI. The treatment for the female is the same. But here the sperm is the one that has a problem. So we take the sperm that is available and we inject it directly into the egg, the small cannula. So that's an assisted reproductive technology that is addressing sperm issues. Now, beyond that, you may have no eggs, but we have a guy who's got sperms, or we've got sperms that have been donated. We can ask someone else who is younger, who is willing to give us eggs. They're called donors. And we create embryos from them, but we give you the embryo to carry. Okay. Now, a lot of the things that you hear surrounding this is when you see 48 or 70-year-old woman in Uganda pregnant. Those were not her eggs. Unless she had frozen them when she was young.
Yeah.
I want to just say categorically.
Yeah.
She was not 50 and produced some miraculous eggs.
No.
That is someone who had eggs from before or has had someone donate eggs and they have carried the pregnancy. So we can be able to play around with the uterus using hormones to be able to carry a pregnancy.
Right.
What we don't have yet is creation of new eggs.
Right, yes.
So that bit... I don't think we'll ever get there. This is just my...
But you never
science
know.
is coming.
Again, the way science is moving,
is coming.
we're
There's a lot of
transplanting uteruses now. So
We've got some stem cells, I think Japan or China, somewhere. They're taking stem cells. It's like cells that don't have a definition from before, and you almost define them to start producing what to become. So we don't know.
We don't know yet.
I'm excited to see what that looks like. So all that is assisted reproductive technologies. Yes.
So then, because again, in Kenya, the one you'll hear the most about is IVF.
Yeah.
And you've described IVF as we're going to take eggs from, usually stimulate, and then take eggs from the female, and then take sperm from a donor or the partner, bring them together externally, and then implant an embryo. Yeah. We have, again, Kenya, my lovely country. We have people purporting. Yeah. Everywhere you go, come and we do IVF. Come and we do IVF costs this much. IVF costs this much. And therefore, come in and we do IVF. And one of the things I've seen a lot of is either a misdiagnosis. And so what you're getting is not necessarily IVF. It's another form of assisted reproduction. Yeah. Or... we take out we make embryos, we create nicely, and we implant and don't give you the option to freeze. So just walk me through. Mimi, Sandra.
Yes, Sandra.
Now I'm Sandra.
Sandra, how old are you now, Sandra?
Now I am 38.
38.
I'm 38 years old. Thanks to a conversation I had with Dr. Muchiri when I was 28, I have a few eggs sitting safely somewhere.
All right.
And now I've come.
Okay.
And I think I'm ready to have a baby. Like in my corporate push, partner, tricks.
There's no partner
not
here.
Materializing.
Okay.
It's not right. Again, this is the reality for many people at the moment. Yes. So there's no partner, but I feel I am ready. Okay. So what are my next steps? What are my options?
All right. So it's nice that you've then already considered and have frozen some eggs before. What I'll do is try and tackle this as if you also had never frozen eggs. Yeah. Because most of the people actually haven't frozen eggs. Yeah. But if you have frozen the eggs, so let's start from the very beginning. How IVF works on a day-to-day sort of basis is we take a history. So for example, have you ever been pregnant before or not? Because remember, it could be something else. It could be the uterus that has a problem. True. It's not your eggs. True. Okay. Yeah. So if you've ever been pregnant before, we are very happy. We get so excited because that uterus can accept an embryo. Science hasn't developed that. There's a lot of research that's working. So to look at if you have a good embryo, you're young, good eggs, why are you not getting pregnant? Sometimes it's that the ovaries, the uterus itself, but it could also be other hormones outside of the reproductive health, reproductive system that are causing a problem. Yeah. Okay. So, but far from that, at age of 35, so how we classify IVF and how we think about it is you've got the ladies who are less than 40. Normally they tend to be 35 to 40 years old, people who are looking at IVF treatment and are feeling ready to get pregnant. Yeah. And then you've got the 40s to 45s sort of space. And then we've got under 35. So under 35, best time to be trying to conceive or doing IVF, because the success rate from those eggs is usually about 30 to 50%. Okay. When you are coming towards 40, it comes to about 10 to 20%. By the time you're 45, it's going to be 1 to, let me say less than. Yeah. It's very dramatic. Yeah. So you want to come earlier. Even if you don't have a partner, it's better to come and have the information and do something earlier. Rather than trying to be at a space when you're 45. So I'd be very happy to see you at 38. Now when you come in, we investigate and see what your ovarian function what we call the ovarian reserves. So we do a couple of tests. We do a blood test. It's called the anti-Mullerian hormone. It's looking at the activity of the ovary at that point in time, meaning it changes. It doesn't remain constant. So we may do that test and we say, you've got quite a good ovarian function. There's no rush. Wait a little bit. Or this is looking not very good. Let's do something. Okay. And then we also do scans. And these scans, luckily, we're in an era where we can scan through the vagina. It's called a transvaginal scan. And we count the follicles, which is inside the ovaries where the eggs are sitting. Gives us a rough idea of what you're doing month on month. It's not exact. So if your doctor says your atrial follicular count is 10, it doesn't mean next month it will be 10. It can go a bit higher, it can come lower. That's what helps us to define how we are going to proceed. Now, sometimes you also have a lot of eggs. There's a group of patients who have polycystic ovaries. Ladies who have PCOS, it's very, people especially in Kenya just like, nikona PCOS.
Nikona PCOS, everybody.
Kila mtu akona PCOS. PCOS is not equal to infertility. You can still get pregnant. Exactly. You may have other things, but you can get pregnant. But the ones who struggle to conceive, it's that they're not releasing the eggs, they're not ovulating. So for them, they have many follicles. I think my latest, I collected nearly 58 eggs from just one lady. Okay, so a lot.
Okay. That's a lot
of eggs. So that's the other extreme, because PCOS, then you've got lots of eggs, but you don't get regular periods. Therefore, you will not be releasing eggs. So remember our anatomy and our talking about like where pregnancies come from. So if you're not ovulating in a year, maybe ovulate 2 or 3 times, then you will have difficulty conceiving. So IVF means that we give medication to talk to your brain above what your brain is telling the ovary, so that instead of this one egg that you are releasing, you release more eggs. You make more eggs. It's just playing around with your body. And then when you make more than one, then we are able to put you to sleep. Sometimes we just put local anesthetic. It depends on how well you handle pain, and we can collect those eggs. So if you are doing egg freeze before at 28, that's what you did up to that point.
So
it's
I
all
have
the
a
same.
kitty of little
you
eggs
have eggs.
waiting.
So if you are 38 now and you didn't have eggs, we'll still do the same.
Okay.
We'll make you produce many eggs so that we can collect them. Now, typically, we want about 6 to 12 eggs. Will give us 1 to 2 embryos. They drop dramatically, which is very disheartening even for us, because you could have 20 eggs. You may just get 3 embryos to transfer. Across the world, we want to put maybe just 1 or 2. If you're above the age of 40, maybe 2. Because you also don't want to put so many. Embryos can split once you put them in the uterus. So then they become multiple pregnancies.
True.
People think it's fun.
Listen, the number of conversations I have.
I want twins, Daktari.
Daktari, I want twins. I want triplets. I'm like, you want stress for me. That's what you want.
And stress for you.
Because
stress for you, because those babies might not make it to full term.
True. And the way your body will be in the pregnancy, like we consider that a high risk pregnancy.
So we want, at the very least, if we put 1 and then we get 2, if it splits, then we have 2 babies. We can deal with that.
We're happy with that.
But this 3 business for sometimes we have to terminate a pregnancy because it's going to be very difficult pregnancy to manage.
And imagine after everything you've gone through.
Imagine coming to find me at 18 weeks to tell you, I don't think we are going to, or delivering. I've had 22 weekers born, and the care for those really, really tiny babies is very difficult.
Just difficult.
It's difficult, and this is across the world. So that's going to be what IVF looks like. So for you then, it will be either we are removing the eggs we had frozen from when you're 28. This technology is so fantastic. My God, it's so, I think it's so clever that we can freeze them in time. And when we thaw them, they are the same.
28.
They're still 28. Even if you're 40. They're 28-year-old eggs. This is just like magic, I think. That's why I like this job of mine. So we will thaw the eggs and then we'll take the sperm. Now, this sperm could be your own partner. Now you've got a partner, or it could be donor sperm. And we put them together. And at that point is when fertilization happens. Now, for frozen eggs, we generally tend to do ICSI, just because sometimes the shells of the eggs become quite hard and it's difficult to play around with them. So we inject the sperm directly into the eggs. But if we are collecting fresh eggs, we don't have to do that. We can put the eggs just together with the sperm, fertilization will happen, and then we'll put that 1 embryo, and everything extra, then you freeze. Now, interestingly, of notice, say you're 38 and now it doesn't look like there's a partner, you may or may not get someone. You can create embryos and also freeze eggs. I have patients who do that.
Okay.
Because then embryos will survive better
Yeah.
when it comes to thawing them in future. Eggs are not as stable. So it's a good option to have. But if you take eggs and embryos against each other,
Embryos are superior.
Embryos are superior to survive in the thaw process.
Yeah.
And now more and more we have couples who say, by the way, I have some frozen embryos, but I also have eggs. And the guy will be like, it's okay.
Yeah.
Interestingly, men don't have such a big attachment to children. I think for men, taking care of a child is quite important for them, as opposed to, this is my child, this is my genetics. Women struggle with that concept more, if it's a donor egg, for example.
That's actually true.
Yeah. So we'll get round to it, but sometimes it's quite difficult to do that.
Yeah.
So that's what your journey would look like.
Okay.
Yes.
All right.
Now, if you produce too many eggs, for me, it's usually above 20. I don't put an embryo back in.
Okay.
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 There's something called ovarian hyperstimulation. Now, ovarian hyperstimulation, the hormones are really high. So remember, you usually have just one egg.
Yeah.
So if I have 20 eggs, you have 20 times the amount of estrogen, which is a hormone in your system.
Yeah.
It will make you feel sick, nausea, vomiting. You can get clots in your legs. You can have fluid in your lungs. It can be quite dramatic.
Yeah.
Now, making you pregnant worsens it because a pregnancy produces a hormone that's called HCG. That can send you even to ICU.
Yeah.
So if I'm seeing that you're not doing very well clinically, we still go ahead and collect the eggs, but then we freeze them, wait for your body to settle down, and then we can put an embryo at a later time.
Right.
Yes.
I like that you've mentioned ovarian hyperstimulation, because it's something that women feel very distraught if it happens, because there's the belief that now I've lost the opportunity to be pregnant. But like you've said, you can preserve the eggs that you were able to retrieve. It's not an entirely lost cycle. And then when you're ready, when you've recovered fully and you're back to being stable, now we try to go ahead with the implantation.
Yes.
Yeah.
Now, one bit that I had forgotten is, especially for our polycystic ladies, we can give you tablets. So you don't have to have IVF.
Right.
So we can give you a tablet. It's called ovulation induction. We give you a small tablet you take just for 5 days between day 2 and 6. We monitor to see that you're not producing too many. Usually we just want 1 or 2 follicles.
Right.
And then you can even have timed sexual intercourse with that one. So we monitor, we say, okay, now we are happy. Now you can have sexual intercourse.
Yeah.
Or we can do insemination, what I discussed. So we can then plan for you to come and we put in the sperm and you can get pregnant. So that's also still under reproductive.
Yeah. So no, that, like you said, it's exciting that the field has come a long way.
Oh, gosh, yes.
And especially so here in Kenya, because we've opened the doors to allow for options to be available to our patients. And again, there's no shortcut. You have to come in.
Yeah.
And have the conversation so that we are able to explore what options are available to you. Now it's just parting shot. Is there something you feel, because again, lifestyle, for me, lifestyle is still something I don't think they hear us, because when we talk about alcohol and drug use, and nowadays we smoke everything under the sun, and it's become pretty much part of the culture. Parting shot to our young people when it comes to thinking about fertility, especially if you are keen to then have a family later on. What can I do to best preserve my chances, or at least improve my chances of being able to conceive when I'm ready to?
I mean, very big on my agenda right now, first is this thing of multiple sexual partners. And I know people want to bury their heads in the sand and just pretend.
Yeah.
They pretend it doesn't happen.
Pretend we don't know it's happening. We pretend we are not doing it.
Yes.
We are not. In fact, who are you talking about?
Yeah. Who? Me?
Really?
No. And these multiple sexual partners, by the way, could be at the same time or serially. So if you're in these relationships of 2-3 months, another 3 months, another like this.
Also, because there are whole relationships these days that last 3 months.
Yes. The people have
this
major
is how
heartbreaks.
we're showing our age right now.
So this is quite,
Yeah.
And protected sexual intercourse is actually a difficult thing to do. Many people don't realize how, I ask my patients, do you use condoms, for example? And they go like, yeah. And then I said, okay, when was the last time you had sex? And we are very intrusive. We sound very intrusive, but that's why we ask these questions. Because you say, last week I had sexual intercourse. Good. How many times in the night? 5. How many times did you wear a condom? They never wear 5 times. Ever.
Never.
It will be the first one.
Yeah.
After that,
Very
things are
likely,
just very downhill.
Maybe the second one. Beyond there.
Beyond there, it's all going downhill.
Yeah.
And unfortunately, you don't know who you're with. I mean, you could think that you do, but if that person is with someone else who's got something, they can easily transmit to you. Men are fortunate in this way, in that they get symptoms. It's very obvious. But even the men will have symptoms and they'll get treated, and they don't tell
the partner.
The partners, the multiple, the 10 chicks, they are never told.
True.
Which is so sad.
Yeah, and the fact that we've said most don't have symptoms, so you don't even know.
The girls will not know the symptoms, and it's very sad that they will come and their tubes are blocked. And if you ask the lady, do you have any idea where this might come from?
Could have
no idea.
There's no. In fact, contact tracing is the biggest rumor these days.
It's very hard.
Did you get it this time or last time or a few years back? We have no idea.
And like for us, when we treat in IVF, we always do a chlamydia test. Not just because of the potential of blocked tubes, but you can then push chlamydia in our procedures into the tract. So where there was no problem, then you can cause a problem. So we'll always check. And the amount of times people get like, I have chlamydia. I had chlamydia.
Yeah.
When did I have it?
When?
You
From
tell
who?
me where you had it. I don't know where you had it. So I mean, that education and just getting ourselves sort of, talk about it. Talk about it. Women, you need to just be empowered by yourselves.
Yeah.
Please don't expect that the guy is the one to remember that you should wear the condom, please. Because it is your tubes, by the way.
As you're making the decision to be with this person physically, also make the decision to investigate.
Yes.
And then protect yourself.
Yeah. And always, you are the one. Have your own condoms, by the way. I don't understand this thing of the guys are the ones bringing the condom. But please just have your own also. Put your stash somewhere so that you tell me, 1 second. Please wear this one.
This is what I require.
If not, there's diaphragms. There's also options for women, which I don't think we talk a lot about, but have some protection of some kind. Or just abstain until when you're ready to get a child. So this is the education bit of it. Then there's the nutrition. Lots of fruit and vegetables. Let me tell you, I still have fights with some of my teenage cousins about fruits and vegetables.
It's like punishment.
Yeah. I'm like, wow. Yeah. I wonder if I was like that. I always ask myself I was like...
Probably were.
You'd
be given vegetables and you stuff them under something somewhere.
And you're like, I don't eat those ones.
I just want the meat.
I don't want cabbage. I don't want... it has an impact. And those kind of foods are rich in antioxidants. And that helps with rejuvenating even your skin, but also other body parts. So lots of fruit, lots of vegetables, healthy stuff. If you are having an occasional, piece of cake, some of my relatives are such sweet teeth. Too much.
Too much all the time.
But
again, we say in moderation.
In moderation.
There's some things, honestly, this is also life. Yes. We're not trying to make you live by such high standards.
Bad, prescribed, and you'll be so miserable.
Yeah, true.
I mean, some of my relatives, if they don't eat that cake, they'll be moody. They'll be, I just give them some cake.
Just give some cake.
Some biscuits here and there. Yeah. But just looking at that. And then exercise. And exercise is both cardio, activating your system, and weights, weightlifting, weight bearing. It's just good for your own general health, but it's also very important for your mental health.
True.
People don't understand how difficult it is to go through an IVF cycle. It's distressing. I have had to most times put my medical hat aside to discuss the emotions that go with IVF. It
is quite, in fact, heavy. Psychologically, emotionally, it's a lot.
It's a lot to go through a cycle.
We end up having to support so much because you feel like your body is not your own. If you're thinking about the normal changes and how you handle your hormones before your period, as you get PMS symptoms or during pregnancy and the changes that happen then, what you go through with IVF can be brutal.
It's very brutal.
And again, another thing we don't discuss. Yeah.
I don't know. I hope we get better, but it's also back to the assumption that if I was having a problem, the doctor has now given me some medication, I must then get pregnant.
Yeah.
But it's not always
It's
that
not
you will. An
guaranteed,
IVF cycle is very expensive, and it can end up with zero outcome, no pregnancy. It's disheartening. And then sometimes you have been in that process for so long, you lose yourself as even the woman. The man doesn't know how to support this process. And eventually a pregnancy comes. I've had patients who have terminated IVF pregnancies, believe it or not.
Oh, wow.
Because it was so much investment in the trying to get pregnant. You then get there and you suddenly realize there's a child coming. I'm not ready.
You're in distress. Your mental health is in
the pits, and you are just like, where is this child going to stay? I have no idea.
That's actually devastating.
You start looking at this child as, I've invested $1 million plus, Bob, to get this child. The child is not here yet. What will happen when they arrive? And that has made women terminate pregnancies. It causes a lot of strain also on couples, just because, the things that the lady is feeling, the man might not be able to understand. If you have a miscarriage, even just of a natural pregnancy, it's a very heavy thing to go through. Imagine for IVF, where you've invested that much time. Miscarriages can still happen. IVF does not mean a miscarriage cannot happen.
Any other risks that come with normal pregnancy or normal conception are still there.
Yes. So it causes a huge strain on couples. I've seen couples separate once they've been successful with IVF, which is really unfortunate.
Okay, that's good takeaways for us to think about. I think I'll leave it for the audience, because we can talk here. We can talk until tomorrow. But I'll leave it up to the audience to ask questions. If there's something that you've heard about and you want to know more of, I'll put Daktari's places to find her.
And people I
where
work with.
to find her, and the people that she works with in the description box, so that you can just reach out, start a conversation, have a consultation. If you're not within Nairobi, go to your nearest doctor. Wherever you are, start the conversation with a doctor, and then let's see what is required for you. But again, Daktari, thank you so much.
Thank you.
This has been very enlightening. Like I said, nitakuwa napo nyuma ya tent.
See me.
We continue this conversation. For the audience, thanks for tuning in. Thank you so much for watching. Those of you who are listening, please send those DMs, send those emails, leave a comment, like, and of all above and beyond, please subscribe. And I look forward to seeing you again on the next episode.